Salivary gland disorders part 2. This lecture will be presented by Dania Mu'taz Group B1. Today I'll be talking about mumps, salivary, xerostomium, Sjögren's syndrome, and some of the benign and malignant tumors that occurs in the salivary glands. Starting with mumps, or paramyxovirus or epidemic parotitis. It's an acute viral infection that is caused by the RNA paramyxovirus and transmitted by direct contact with salivary droplets. Mumps typically occurs in children between the ages of 4 and 6, and it takes about 2 to 3 weeks of incubation period since the patient has firstly been infected. However, almost 20% of patients do not actually suffer from any symptoms at all. Initially, there is a prodrome of a flu-like symptoms. Headache, arthralgia, loss of appetite and nausea, fever with low grade, or dry mouth are the prodromal symptoms. Over the next few days, the classical symptoms of mumps will appear, and that is a swollen, painful parotid gland causing the child's cheek to puff out. On rare occasions, adults may contract mumps with the same general symptoms but more severe complications like meningitis, encephalitis, pancreatitis, and deafness. The mode of transmission for mumps is typical for any other paramyxovirus. It travels from the respiratory tract to the salivary gland where it reproduces itself, causing the gland to swell. Sneezing, coughing, using the same stuff for the infected person, kissing him, sharing food and drinks, or maybe the infected child touching his nose and mouth and spreading all over the place will cause the virus to transmit. Individuals infected with mumps are contagious for approximately 15 days, 6 days before the symptoms and 9 days after the symptoms starts. This is a clinical picture of a child with a puffed parotid gland. And this is an intraoral view of the parotitis with a swollen stencil duct orifice. During the acute mumps infection, diagnosis is made by either screening for the virus using saliva or urine. Several tests are available like the buccal swab PCR, antibody test, salivary culture, spinal tap, and pancreatic enzyme testing. Treatment is symptomatic and may involve the use of analgesic and antipyretic. The measles, mumps, rubella vaccine is usually given in a combination with varicella vaccine. It comes in 2 doses with 4 weeks period apart between them. The next topic we're going to talk about is salivary. Salivary is an uncommon condition that has various causes. Minor salivary may result from local irritation like aphthous ulcers and ill-fitting dentures. Episodic hypersecretion of saliva, or what we call water brush, may occur as a protective buffering syndrome to neutralize the stomach acids in patients who are suffering from gastrointestinal reflux disease. Salivary is a well-known clinical feature of rabies and heavy metal poisoning. It may also occur as a consequence of certain medication given to treat Alzheimer's and myasthenia gravis. On the other hand, patients with cerebral palsy who have excessive drooling associated with significant morbidity such as skin maceration, poor oral hygiene, or dehydration, and patients who have failed to adequately respond to the appropriate physical and chemical therapy are more candidated for the surgical therapy. So, many surgical approaches can be done in the treatment of sialorrhea. We can either do the bilateral parotid duct division, which is the Wilk type procedure, with excision of one submandibular gland, or with excision and ligation of both submandibular glands. We can either do the excision of submandibular gland with or without the parotid duct ligation, and I'll be talking about that in a minute. Or we can do the relocation of the submandibular gland duct with or without the removal of the sublingual glands. Lastly, we can do the tympanic neurotomy or condylotympanic neurotomy. I want you to notice that the condylotympanic nerve supplies the anterior two-thirds of the tongue, and also have a secretory fibers that goes into the submandibular and the sublingual gland. So, neurotomy or removing this nerve will always result in loss of sensation in the anterior two-thirds of the tongue. This is actually one of the disadvantages. A recent approach is by injecting botulinum toxin into the parotid and the submandibular glands. Now let's learn more about the parotid duct ligation. First, we give the patient general anesthesia using the nasotracheal route to provide good oral exposure. In picture A, you can see the lacrimal probe is inserted into the parotid duct to stabilize the papilla. 1% lidocaine with epinephrine is injected into the mucosa surrounding the papilla to aid in hemostasis. Picture B shows an elliptical incision made around the papilla. In picture C, you see the papilla is grasped using a clamp and retraction is placed on the duct while dissecting the duct to free from the surrounding tissue using a scissor. In picture D, you see the duct is ligated twice with 3-0 silk suture, and the papillary mucosa is excised by transecting the distal portion of the duct. The duct is allowed to retract into the soft tissue of the cheek, and the oral mucosa is sutured loosely with a 3-0 chromic suture. Xerostomia refers to a subjective sensation of a dry mouth, frequently associated with salivary gland hypofunction. A number of factors play a role in causes of xerostomia. Upon physical examination, we'll notice the reduction of salivary secretion, where the residual saliva appears either foamy, thick, or ropey. The mucosa appears dry, and the clinician may notice that the examining gloves will stick to the mucosal surfaces. The dorsal tongue often appear fissure and atrophied filiform papillae. This is a case of patients suffering from acute xerostomia. You can see the increased salivary viscosity, patient complaining from difficulty in speech, mastication, formation of food bullets, and swallowing. Sjögren's syndrome. It's a multisystemic autoimmune disorder that principally involves the salivary and lacrimal glands, resulting in both xerostomia and xerophthalmia. We can also call xerophthalmia as the keratoconjunctivitis. Two forms of the disease are recognized: the primary or Zika syndrome, the word Zika means dry, and the secondary, in which the patient manifests both the Zika syndrome in addition to another associated connective tissue disorders, and most of the time is the rheumatoid arthritis. Although the cause is unknown, there's a strong autoimmune influence that seems to be present. This syndrome occurs in females 9 times more than it occurs in male, with the mean age is of 50 years. The oral symptoms are the general symptoms of xerostomia. Notice in this patient that there is a lack of the usual pooling of saliva in the floor of the mouth. The affected patient may complain from difficulties in swallowing, altered taste, and difficulties in wearing dentures. There's a more tendency toward the related denture sores and angular cheilitis, and because of the lack of salivary cleansing action, the patients are more predisposed to dental decay, especially the cervical caries. From one third to one half of patients have a diffused firm enlargement of the major salivary gland during the course of the disease. This swallowing may be bilateral, and it's more often non-painful or slightly tender, and it may be intermittent or persistent in nature. The greater the severity of the disease, the greater the likelihood of this salivary enlargement to happen. The Schirmer test is used to quantify the lacrimal flow reduction, in which a filter paper is placed in the ocular pharynx and observed for about 5 minutes. It's considered to be normal if the person can wet about 15 millimeters. Less than 15 millimeters is considered to be dry, and it's either mild, moderate, or severe. In this picture, you can see a 63-year-old woman diagnosed with Sjogren's syndrome. Notice that she has angular cheilitis, cracked lips, and dispapillated, fissured tongue. This is a case of a woman presented with a benign lymphoepithelial lesion of the parotid gland. Upon taking cyanogram, you can see the atrophy and the picturate cyalolactasia, which is the appearance of a fruit-laden, branchless tree. One of the diagnostic methods is taking a biopsy for the labial gland. This biopsy shows multiple lymphocytic foci. Treatment for Sjogren's syndrome is associated with the symptoms. So for dry eyes, the best management is using artificial tears. In addition, attempts can be made to conserve the tear film through the use of sealed glasses to prevent evaporation. Sealing the lacrimal puncture at the inner margin of the eyelid also can help in blocking the normal drainage of any lacrimal secretion into the nose. For the oral manifestation, artificial saliva are also available. We can advise the patient to use sugarless candy or gum that can keep the mouth moist. Symptoms often can be relieved by the use of oral hygiene products like biotin toothpaste and mouth rinses. The cyanogogal medications such as pilocarpine can be helpful to stimulate the salivary flow, and antifungal therapy are often needed to treat the secondary candidiasis. Non-steroidal anti-inflammatory drugs such as ibuprofen are recommended for joint pain that may accompany Sjogren's syndrome. We can also use low dose of a steroid like prednisone and use the disease-modifying anti-rheumatoid drugs, which slows the effect of lupus and rheumatic arthritis, and have been successfully used to treat Sjogren's syndrome joint pain. Now let's take a look at most common benign and malignant tumors that happens in the salivary gland. The first one is the pleomorphic adenoma, which is the most common benign tumor that is mostly found in the parotid gland and in the palatal minor salivary glands. The origin of this tumor is thought to arise from the myoepithelial cells, and that's why when we take a biopsy, we'll notice two types of cells, the myocells and the epithelial cells. These tumors are typically presented as a slow-growing, painless mass, and there is no fixation either to the deeper tissues or to the overlying skin. So these are the clinical presentation of patients suffering from pleomorphic adenoma. Notice that the swelling is not perforating or ulcerating the overlying skin, and it can happen in the parotid gland or in the submandibular gland. The principal treatment is complete surgical excision with serif margins, And for the parotid lesion, it's treated with removal of the involved loop, which is either the superficial or the deep loop, or maybe both of them. Recurrence is possible, but it's rare, and there's a small risk of malignant transformation. In this section, we'll discuss the removal of a diseased submandibular gland. Prior to the operative surgery, the patient is given intravenous antibiotic and general anesthesia through the oral endotracheal intubation. Seat the patient in a supine position and hyperextend the neck. Rotate the head to the contralateral side. Mark the proposed incision approximately 3 cm below the inferior border of the mandible and extend it anterior to the anterior surface of the sternocleidomastoid muscle. Infiltrate 2% lidocaine with epinephrine into the submucous tissue to aid in hemostasis. The incision is firstly through the skin, the submucous tissue, and the platysma muscle. Then do a subplatysmal flap superiorly to expose the superficial aspect of the submandibular gland. Make nerve stimulation to assist in the identification of the marginal mandibular nerve. Free the gland from all its attachment. The duct and the vessels are divided and ligated, and the lingual nerve is retracted superiorly after division from the ganglion. Examine the diseased gland and notice the classical cut potato appearance of the pleomorphic adenoma. Lastly, view the surgical field after resection and then close the surgical site in layers and use the passive Penrose drain in place. Papillary cyst adenoma lymphomatosis. This tumor, also known as Wharton tumor, it's a benign neoplasm that happening almost exclusively in the parotid gland, and it's the second most common benign tumor of the parotid gland. This tumor will represent as a slowly growing, painless, but nodular mass of the parotid gland. It's most frequently to occur at the tail, near the angle of the mandible. The peak incidence is in the 6th decade of life, with the male to female ratio about 7 times more, and an association with smoking. It's believed to be caused by entrapment of salivary epithelial rests within the developing lymph nodes. The histopathological examination shows an epithelial component in a papillary pattern and a lymphoid component in a germinal centers. The treatment is by surgical removing. These tumors are well encapsulated and seldom reoccur after removal. This is a case presentation of a 64-year-old male presenting with Wharton tumor. Note the low position of the swollen parotid gland. Oncocytoma. It's a less common benign tumor that makes up less than 1% of all the salivary gland neoplasms. This tumor occurs most exclusively in the parotid gland and the minor salivary gland. It's most often bilateral in presentation like the Wharton tumor, and these tumors appear as a non-cystic and firm. The treatment for the parotid oncocytomas is a superficial paroidectomy with the preservation of the facial nerve. That is when the patient after surgery will still make his facial expressions well. You can see in the histopathological examination that it predominantly happens in the upper lip minor salivary gland. That's when we call it the canalicular adenoma, or it may be happening in the parotid gland. That's when we call it the basal cell adenoma. The mean age of occurrence is 61 years, and the lesion usually present as an asymptomatic, freely to move, movable mass. On the histopathological examination, we'll see an encapsulated lesion composed of only one type of cells. And the treatment of adenoma is a simple surgical excision. This is a canalicular adenoma in the upper lip. Moving on into the next category of tumors, the malignant tumors. The most common one is the mucoepidermoid carcinoma, which takes about 10% of all the major gland tumors and 20% of all the minor gland tumors. It is clinically present as a painful or ulcerated submucous mass. Notice in this picture that there is a mass in the palate with a slight bluish tint, and that is because of the entrapment of mucus inside the lesion. It may also perforate the skin and make an ulcerated pattern. The intraosseous form of the mucoepidermoid carcinoma present as a multilocular radiolucency in the posterior mandible with a raised lesion of the retromolar pad. The mean age for this lesion is about 45 years, and the male to female ratio is 3:2. Treatment of low-grade lesions is with wide surgical excision and safe margins, while for high-grade lesion it requires a more aggressive surgical removal with the surgical margins and possibly local radiation therapy. Of course, low-grade lesions have much more higher survival rate. The second topic is the polymorphous low-grade adenocarcinoma. The most common site of this tumor is the junction between the hard and the soft palate, and it shows a neurotrophic predilection for invasion along the surrounding nerves, which clinically leads to paresthesia in the area supplied by the involved nerve. The male to female ratio is 3:1 with mean age of 56 years. This is a tumor present as a slow-growing asymptomatic mass that becomes ulcerated like in this picture. The third most common intraoral salivary gland malignancy is the adenoid cystic carcinoma. This tumor happened in a mean age of 53 years old with male to female ratio 3:2. Approximately 50% of these tumors are for the parotid gland, and the other 50% are for the minor salivary gland at the palate. This lesion clinically present as a slow-growing, usually non-ulcerated masses with an association of a chronic dull pain. When the parotid gland is involved, it may result in facial paralysis as a result of the neotropism. Similar to the polymorphous low-grade adenocarcinoma, the facial nerve is involved. Of course, the treatment for this tumor is surgical excision followed by radiation therapy. Yet, the prognosis is poor despite the aggressive therapy. This is a clinical picture of a patient suffering from adenoid cystic carcinoma of the palate and the buccal mucosa. Upon taking a histopathological examination, we can see three types of this tumor. The most common one is the cribriform pattern, in which the basaloid cells are arranged in a cribriform or a Swiss cheese pattern. You can see the resemblance, right? These pictures show us a case presentation. The first one is adenoid cystic carcinoma and the palate, and it's very similar to the appearance of the polymorphous low-grade adenocarcinoma. This adult male with left facial paralysis also called by this tumor, and in these two pictures you can see the post-operative facial function after 2 years from the left malignant parotid tumor resection with intratemporal interpositioning facial nerve grafting. This is the end of my presentation. Thank you so much for listening.